We go. Thank you, Beth. And good afternoon, everyone, and welcome to our virtual education program. My name is Beth Bennett, and I'm one of the education and outreach coordinators with the Alzheimer's Society of Nova Scotia. I am zooming in from Antigonish County today, and I want to thank each and every one of you for joining us online and learning more about this very important topic. So we will be taking questions throughout the presentation. So if you do have a question, please feel free to ask them using the private confidential chat box, and that is addressed to the Alzheimer's Society of Nova Scotia host. To see that, you just hover your mouse near the bottom in the middle, and there should be a chat button there. So if you click on that, it should pop up for you. So you can simply type your question into the chat and then remember to press enter. And that way the Alzheimer's Society host will be able to see your questions, and we will be sure to address them after the presentation is over. So our audience today includes people living with dementia, people caring for someone with dementia, and those who want to learn more. A reminder that this session is being recorded, so your microphones and your cameras have been turned off. So your faces and your voices will not be a part of this recording. Today's topic is about behaviors. What could they mean, and how to best support people living with dementia? It's a topic that we are getting lots of questions about, and based on the response, a lot of people want to have a conversation about it. So I'm really happy that we're covering this important topic. And if some of you online today have been involved in our family caregiver education series, you may have seen some of these slides before from our session 5, which is understanding dementia behavior. It's always great to hear things a few times, and Leona has her particular behavior resource consultant lens, so she brings different examples and expertise. She really is an expert on this topic. So we will have a 20 to 30 minute presentation followed by about 20 minutes of Q&A. And now it is my pleasure to introduce Leona Wilneff, who is a behavior resource consultant with continuing care for the Eastern Zone, which is in my neck of the woods. Leona is a registered nurse of 25 years. She has worked in the areas of long-term care, home care, and acute care, with a clinical emphasis in palliative and dementia care. She supports care providers with education and consultation to facilitate assessment and care plan development for people living with neurocognitive disorders like dementia. Before I hand it over, I want to say a big thank you to Leona, who has partnered with the Society on a number of programs and facilitated sessions with us. So I want to thank you for always being willing to share your expertise, and thank you for your time today. Leona. And we just have to unmute you, Leona.
How's that? Can you hear me now?
Yes, thank you.
Thank you, Beth. And welcome, everyone. I'd like to just start by saying I don't consider myself an expert, though I do have experience working with care providers and people living with dementia. And I'm going to use the term dementia as a broad definition of what we would refer to as a set of symptoms that result from many various diseases, the most common being Alzheimer's disease, but certainly all of those neurocognitive disorders, disease processes, whether it be post-stroke, Lewy body dementia, Parkinson's, Huntington's, and the various diseases that we may or may not be familiar with. I'll just broadly use the word dementia to refer to kind of the goals of our discussion today. So we'll move on to the objectives, and this is what I hope certainly you take away from our discussion today. Next, Beth. Okay, thank you. So we hope to increase your awareness of how behavior has meaning. And that is going to be kind of the foundation of the way we think about behaviors. We do we understand that there is meaning behind what we see, but often it's very atypical in that it's not what we may first perceive the behavior to mean. So really what I'm going to do today is give you a 30-minute overview of what we as consultants spend 3 8-hour days teaching registered healthcare providers to use as a framework to assess and determine those causes of behavior, and then the strategies certainly to mitigate and reduce the most risky of those behaviors. So we're going to move back a little bit, if you don't mind, back to the objectives, Beth. Yeah, so we hope that you'll understand the changes in the brain are often what we see in terms of what we would term normal responsive behaviors or behaviors in general as a result of the failing brain, depending on the part of the brain that's affected. Then we're going to spend a little more time on these last 2 objectives, which is to identify the responsive behavior and why it's happening. And sometimes it's time sensitive. And sometimes that's a really good thing because there's no quick fix in terms of mitigating a behavior or eliminating a behavior. And sometimes we just have to kind of weather the storm, if you will, until that behavior subsides. And then obviously learning supportive strategies to help you, the caregiver, be able to continue to care for your loved one when these responsive behaviors and kind of get in the mix. So understanding behavior and that it has meaning is a predominant theme. What we often see is behaviors such as wandering, and we'd like to term that as searching. And so if we were looking at a specific behavior that is an attempt to communicate to us, then we really have to delve in a little deeper and understand, is the wandering aimless, or really is there things within the searching or wandering that give us insight as to what that individual might be looking for. Some behaviors are the result of disease. So we'll talk a little bit further on in terms of what are those common displays of whether it be personality, capability, perception, use of language. What are all those common losses that we see across, the various types of brain failure and dementia? Because there are some common losses that we see that are not as unique to the individual as much as they are expected to occur as a result of a failing brain. And then lastly, this is the real work in terms of determining what does this behavior mean for this individual. So we'll spend certainly more time on that. Okay, Beth. So it's important to see and remind ourselves that each part of the brain is responsible for certain functions, and understanding, and we may not always know exactly where the disease is affecting, although there are those classic or those cardinal losses that are indicative of frontal lobe, for example. But this is a good overview of the things that we need to consider when we know the brain is failing and these skills are getting lost. So certainly frontal lobe is memory, thinking, behavior. Temporal lobe, you see here more feelings may not be indicative of the situation. Hearing, learning may be impaired. Parietal lobe, language is often not only the perception of what's being said, but certainly their choice of words may not be indicative of what the message is that they're trying to convey. So we need to rely a little less on language as the disease progresses, because we can go down the wrong road in trying to understand the meaning of that behavior if we're relying on words, because and we often see words get pulled that are present for that individual versus truly indicative of the message they're trying to convey. And occipital obviously is sight, and the brain stem and the cerebellum, and this failure is often seen in later stages of the disease. So, yep. So what are responsive behaviors? What are they and what do they mean? And it's really critically important that we learn about the person we are attempting to understand. And there's various ways that we do that. The Alzheimer's Society provide an inventory, a social inventory, a booklet called All About Me. And certainly you can access that resource. And we often say, even among us as consultants, is that we're going to write our own care plan and our own recipe for who we are and what we need when we aren't able to communicate and convey our needs and wants and likes and dislikes, as if we're stricken with dementia. So, you know, when I get upset, what kind of chocolate bar do I want? What did I do for my career? I mean, certainly not uncommon to see a nurse who's done shift work not be a good sleeper, because, you know, you have to check on your clients all night long, your patients all night long. So certainly the person and who they are is significant in this work. And I'll reiterate that and how important that is as we continue through. And us consultants have a comprehensive social profile that we use, and we help caregivers and healthcare providers really populate that with the significant information that we know we're going to need in our toolbox, so to speak, when we're trying to create strategies that are meaningful for an individual with dementia. Because as we know, or we may know, people with moderate to advanced dementia often reference their reality of the here and now 30 years, 20, 30, 40 years prior to today's date. So if we don't know what that story is and what life was and what was important back then, or what those mountaintop memories were 30 years back, then we're really trying to navigate the behavior without all the information we really need. So it's really important to get that social profile among care providers and us all working as a team to understand, what does this mean and why are we seeing this now? Why is she asking for mom? So all of those things will come to play. So responsive behaviors are those actions, words, gestures of people working or living with dementia or caring for people with dementia that express something very important to them in terms of their person, their social connection or their social definition of self, how they are physically, and the environment by which they're living. And it's critically important that we learn about the person and understand that in addition to physical, social, personal, we as consultants help caregivers and the team. And when I speak of team, I mean everyone involved in the care and the family unit and the interactions day to day with people living with dementia. And we also look at the emotional profile of that individual. So if someone has always had anxiety or depression, how does that get interpreted by the individual and then get expressed through behavior? And is their coping mechanisms intact, or do we need to relook at what brings on anxiety, for example, and how we look at assisting the individual to cope? Because basically behaviors are not only a person's way of interacting and communicating and living in their environment, it's how they interpret that external influence by all of these factors. So we really look at the whole picture when we're helping families and teams identify and understand, what this behavior is. Okay, Beth. So understanding behaviors, it's all personal expressions. So it's words, it's gestures, it's actions. They all have meaning. And certainly we do understand that a good portion of what we communicate with individuals is predominantly our body language, especially when the ability to use words and language and perceive and comprehend language is failing them. So personal expression and communicating the meaning is certainly our biggest tool in terms of understanding how we interact with people with dementia. And so understanding the meaning of behavior, we really need to again look at what physically could be going on with that individual, what emotionally are we seeing? Is there a seasonal component, for example? Is there a daytime component? And we really spend a lot of time looking at each of these in isolation to give us a clear picture of not only the rhythm of their day, but all those potential causative factors. Environmental conditions are huge, and they might be influencing the behavior. So really looking at each component in very great detail, really, to determine what's at play. Because the person with dementia is receiving messages based on a failing brain, but everything that's going on around them. And if they can't interpret because of the executive brain being failing, then we have to rely more on new strategies to help them receive the message we want to convey and help continue to interact in a productive way with them every day. So, okay. So triggers and strategies, we want to look at 4 areas, and I want to spend the most of our time talking about these next 3 slides, because triggers and strategies are really, I think, what caregivers are in the end looking for. What is the behavior I see? Now, this behavior may be new, and that's one of the first questions we ask is when we look at a behavior is, what has changed? Is this new? And really, sometimes we get held on that question in and of itself, because if we're care providers in a long-term care facility, often our story and our knowledge of that person starts the day we meet them. I mean, we do get certainly we get an assessment and a history, but the history that we really need to understand and have in our repertoire, if you will, in terms of what we use to guide us, is that story from the earliest of memories. And so we really look at the person and spend a lot of time going back to the early days. And when I say the early days, if we have the benefit of having access to families, then we want to know, and it may be a spouse, and the spouse, we're relying on the spouse recollection of the stories that she or he's been told from when our client was a child. And that's really hard. We go back as far as memory will take us, because often what we realize and find is sometimes it's the early memories that are being relived in their reality, and the behaviors are often the result of that. So we really spend a lot of time around the person. So I always recommend that if you are someone caring for someone with dementia, or if you're like me who's already planning their social profile and their care plan, I would suggest that you start gathering that story so that caregivers have the benefit of working with that. And I also want you to reflect on mountaintop memories. So we see things that become quite significant when someone is moderate to advanced in their disease, whether it be the joyous birth of a baby, or a traumatic event like a house fire, and all of those occurrences, all of those things that happen in life, what are termed what we call mountaintop memories, because they are the ones that are maintained even in furthering, like in advanced disease, and they may get played out by way of, for example, I had a gentleman whose family member drowned, and a trigger for him was the glare of the water on the wash pan when caregivers approached him. And it was a visual trigger that took him back to a very traumatic time in his life. And though we came to that determination, and the strategy was easy to alter to help, mitigate that behavior, it takes a lot of work and discussion among all the individuals who know this person best to help define why we see, or why we might see fears, why we might see sadness, why we might see anxiety. If we can match some of that with their story and their personhood, then it better equips us to reconfigure how we're going to interact with that individual. Environment is significantly important, as you would guess. I mean, some of us are extroverts, some of us are introverts. Some, we may see behaviors often as a result of an environment maybe too quiet, but more often than not, maybe a little too noisy. So we always look at all of these potential triggers and try to determine what is affecting the change in behavior. I mean, if someone is going along okay, and there's various ways we measure this, but if someone's, going along okay in their day and then things aren't okay, then we really look at that period of time and what happened around that individual. So looking at physical, the person, looking at environment, what's the task at hand? Maybe it's bathing, maybe it's mealtime, maybe it's any caregiving task or interaction that you would think of in the course of the day has the potential to be, to result in responsive behavior. And having said that, not everyone, certainly with dementia, is going to exhibit responsive behaviors. It's not a given. But if you can understand that how someone with dementia and the failing brain interprets the world around them and interacts, then we can be attuned to the changes that we see. And we certainly help people identify the subtle changes so that behaviors don't escalate in their intensity, because of the various behaviors we often see, there are those that are riskier, and we certainly want to mitigate those as a priority. And in addition to person, environment, task, and approach, we want to consider back to all of those causes that I previously responded to. But in addition, I want to highlight physical, and that's where we kind of start our assessment as consultants, and we use a framework called PIECES. And what that stands for is we touch on pretty much all of the high points here, but we really start with physical. The P, the I, the E, the C, the E, and the S is an acronym for all the various aspects of assessment that we really spend a lot of time determining what is at work. And physical often is where we find many of our triggers, because if you can imagine, a lot of our people with dementia or neurocognitive disorders, they're middle age and onward often, What comes with that are comorbidities and conditions, other medical conditions that you would expect pain to be a result of, whether it's arthritis or previous broken bones or a bout of shingles and all of those various things. So we spend a lot of time making sure that, the physical integrity of that individual is understood, so that we can eliminate any physical triggers that may be at work. And then we move on to intellectual and then emotional capabilities, the environment, and social. In terms of intellectual, what's significant here and what I've found in my consultations and practice is that how we even address someone in terms of how they identify has sometimes changed the course by which we determine how we're going to care for someone. And an interesting example of that is we were caring for an individual who absolutely refused to receive personal care, and he was quite moderate and advanced in his disease, and he, of course, was new to long-term care and didn't have a familiarity enough, or even what you would consider a friendship with the network of caregivers that were providing care to him. So, in considering his intellect in terms of who he was and what he did his whole life, he was a principal, and how he would normally get addressed in a day-to-day by people would be by Mr. Now, we are friendly people in long-term care, and we know that first name basis kind of implies a kinship and a bit of an intimacy and a casual, friendly environment, but that was reserved for the people in his close network of family. So someone strange entering into his personal space, initiating personal care, was not well received. So we changed our language. We changed the way we addressed him. We used words that were familiar to him, like assignment, Mr. I'm responsible to provide this for you today, and words that gave him a sense of understanding of what the relationship was, and we did succeed in providing care for him, but it was through the lens of understanding the intellect of this person and the personhood and what he would respond best to in terms of a bit of a stranger, trying to provide personal care, which is a very intimate task. And then certainly their capabilities. And this is something that we continually revisit with caregivers, because as disease progresses, we often see behaviors get displayed as a result of a change in capability. So what an individual may be able to do now may change in the months to come, and with that we may see an increase in demeanor, frustrating behaviors, and things like that when capabilities become further jeopardized due to the disease progression. So what we like to do is really look at a 24-hour day, a day in the life of an individual. So what I often suggest to people at home is just kind of jot down what someone is doing and throughout the course of the day. What does morning look like? What do all those big interactions and tasks look like in the course of the day? Mealtime, personal care, socialization time. What do you see throughout kind of a day in the life of? And that's kind of where we match that, or not necessarily match is a good word, but we combine that discussion with the personhood, the story, the social history, the words being used if they're searching, if they're collecting things in the house, if they're doing, you know, a number of behaviors that we would consider normal behaviors. And some of those certainly would be collecting things, as I said, repetitive activities, asking for the same person or the same thing or the same activity. Going to work is often something that someone continues to think they need to be doing at a certain time of the day. So all of these things go into our assessment and our planning. So you want to ask yourself things like, what are the external factors that may be influencing this behavior? And by that I mean, is it a certain time of the day? Is it when a certain person comes to visit? Is it a certain event that happens during the day? What is it that might be influencing that behavior? And then really, when we do determine that we think this might be a causative factor, then we create strategies and we trial them. And often we trial a number of strategies before we discover what, if anything, is going to work. And we do reach a lot of success, but it's really a team effort. What we do as consultants is we help with the assessment process, but the observations that are often critical to understanding what these triggers are by people who know these individuals best and who spend time with them. And an example of many examples, but one in particular that I recall on in long-term care was the housekeeper actually had a piece of information that was critical in understanding why a lady that staff reported to be exit seeking, why her behavior was what it was. And she indeed was not exit seeking. She had cleaned a hotel for many 30 years. That's what she did. And every day after work, she would look out in the parking lot, see her husband parked there to pick her up after work, and off she would go. And so the housekeeper actually made the observation that she wanted her mop. Every day around, mid-afternoon, she'd be mopping the floors, and the individual wanted her mop. And it wasn't until we investigated why the mop was significant that we learned she cleaned a hotel for 30 years and she was doing what she would normally do, which was clean the floors and then look for her husband in the parking lot. So she wasn't seeking to go out the window, out the door. She was looking for her husband. So often what we discover is the pieces of information that become critical to help us solution find is by, incidental. It's by people who we don't necessarily expect to have the tidbit that makes all the difference. So, so will the solution cause more anxiety than the problem? And that's what we always aim to evaluate is if we create a strategy, is that causing, a bigger response? And sometimes it does. But we work closely together to be sure that our plan is liquid and ever evolving based on what we observe, because you're going to see changes. You're going to see increased frailty and increased struggles in navigating, a very complicated world when you think of the fact that they don't have, as the brain fails, they don't have the same resources to draw on to interpret that world. So we look at the various behaviors, and there is an assessment tool that we use as consultants called the Cohen-Mansfield, and it lists about 30 common responsive behaviors that could potentially cause challenge, and we determine what are the behaviors that we're talking about, and then from there we really prioritize, because not all behaviors have risks. They may be hard to hear many times a day. They may be, annoying, and I don't like to use that word, but as a caregiver, we've all felt annoyed. As a mother, as a caregiver in general, but do they pose risk? So we really help determine, well, let's deal with the risks, the behavior that pose risk, and work from there. Because we're always fearful that there's risks not only to caregivers but to the individual. And what we also want to determine is what brings out the best in people. It's not just about mitigating risky behavior. It's about also in the assessment of determining, where this person is in their reality and what is it they find joy in the course of the day. How do we capitalize on that and not only focus on mitigating behaviors, but working to promote enjoyment and more of it. And the more we can work, work to that avail is certainly what we're interested in doing. So strategy finding is describing the behavior. So we always want to know exactly. So of the list of 29, 30, we've chosen 2 or 3 that we really need to work with, and we really then want to focus in on the few, the 1 or 2. And then we want to describe it. What exactly does it look like? How often does it happen? What's the intensity? Because sometimes in behavior escalation, we see things that are, they may happen a couple of times a week and they're moderately intense and disruptive. If we see an increase in that, then obviously we need to really, focus in on why is this increasing? It's also a good way of determining if our strategies and our approaches and what we've determined as a plan is working, because we would look for we would look for those behaviors to be less frequent, less intense, and less risky. Then we want to look at what happens after a behavior, because often we, and not intentionally, we can reinforce the behavior, and sometimes our response to a behavior escalates the situation. And in the heat of the moment, it's really hard not to respond out of our own fears and our own anxiety. But if we pre-plan what we're going to do when it happens, what's our plan, what's our response, then we're better prepared to not escalate, this situation. So we want to obviously look at the strategies that are going to eliminate the trigger, rechannel the behavior, and distract. So I want to refer you to validation redirection before we talk about your situation, thinking of your behavior. We often try to distract individuals by way of giving them something else to think about in the moment. They want to go to work. They want to leave. They want their mother. They want something that's, in your mind, unreasonable. And so what we often do without preparation, and I've done it as a nurse many times in my early years of caring for people with dementia, is I go from, and this is metaphorically speaking, I go from them wanting to leave the building to me wanting to offer them tea and oatcakes. But there's a process that I highly recommend for caregivers to practice, and it really does take practice, because it's always in the heat of the moment that you need to use this redirection, validation and redirection strategy. But it's hard to think. It's hard to think when all that cortisol is shooting through your bloodstream and your brain is just not working the way you'd hope it to. So really what you want to do, if someone is looking for something, wanting their mom, wanting to go to work, you really have to validate the emotion around that. You have to prepare yourself to connect with them, understanding, gosh, and we practice this with people, and we give them the language and the sentences to use depending on their individual circumstance. But we need to connect with them on the emotional level, understand what they're feeling. So they're looking for mom. Yes, my gosh, your mom was a lovely lady. I loved spending time with her. She always reminded me a bit of my mom when she did this. So make the connection on the emotional level that they're exhibiting. And then from there, you really want to join in, which we did do in terms of, so you validated that they, gosh, your mom was a lovely lady. I understand why you'd want her. Joining them is maybe sharing a little bit of, I wish I could talk to my mom right now, or something of that sort, where you're joining in on their reality. And then from there, you're going to distract them. So mom, if this is the example we're going to use, their mom was famous for her pistachio squares or for her crochet work. And so if you prepare yourself with a recipe of pistachio squares, or a piece of her, one of her doilies, use that as a reference, as a segue from the need to be with mom, looking for mom, connecting and joining, and then redirecting. So now you're looking at a doily in the back room, in the other room, so that now you're making a meaningful connection in terms of fulfilling the need for mom. And then once you're that far away from the desire to go out the door looking for mom, or calling mom on the phone, and mom's been deceased for 25, 40 years, now you're looking at a doily in another room, and you can segue and use the doily as a way to say, let's, this reminds me, I have to put a load of wash in. Can you come and help me? So you're really then moving away from the topic of mom, but fulfilling the need that they have in terms of mom. So some good communication strategies involve approaching from the front, introducing yourself. And example of this quickly, often in moderate to advanced disease, spouses are, individual may not recognize their spouse. So seeing circumstances whereby bedtime becomes a fearful time because there's a strange lady getting in bed with me, or I'm in bed and it's not pre-thought, but you do see sometimes bedtime restlessness, fear, may not recognize his wife as she enters the room the first time. So can always go, where's Jean? You're not Jean. So we work on strategies to reintroduce yourself in a way that you hope they connect with the fact that you're Jean. Invite the person, engage them. So meet them where they are in terms of their reality, and don't take them off topic until you've made that connection with them. Because your fear and your anxiety about getting them off topic, or getting them away from something that you think is risky, that'll pour out of your pores, that emotion. Very fine-tuned. People with dementia are very fine-tuned to our emotion, because 85% of the message we send is our body language. So as much as you can, wear a smile, because that conveys a positive, unthreatening message, always, usually. Be calm, be gentle. Give yourself the advantage of being prepared for an interaction that is not necessarily going to go well. Often we know personal care is stressful, and so preparing yourself is going to help better set the mood in the room. Using your body language is significant. Any physical gesture you can make to help convey your message is important, because again, language often is a challenge for people with a failing brain. Humor, and really again, it's knowing your people and knowing if humor is a good tool, or whether it's a tool that would be considered disrespectful. We had a lady who always interpreted a smile on your face when you entered her room as a smirk, not a smile. So if that's the interpretation of this individual, because maybe of previous experiences with people, or just the nature of a personality, knowing that's significant and important. And humor is along the same vein. I like to use humor a lot, but if that in some way, conveys a message that I don't think their concerns or their anxiety or their frustration or anything that they're living and feeling and dealing with is appropriate, then certainly humor is not a tool you're going to use. Visual cues, very, very important. Montessori is a curriculum that stresses strongly the benefit of labeling bureau drawers, socks, underwear, clothing, certain foods, anything that, because the ability to read labels is maintained a lot longer than the verbal use of the word. So labeling and visual cues are very, very, can be very, very helpful tools. And being patient, and that's not always easy, especially in homes whereby you may not be sleeping well, your supports may be limited. Certainly with the onset of COVID, we've had less access to supports and resources, so that's further taxed caregivers, especially in homes. So being patient is not always an easy thing, but I'm sure, as many of you have experienced, our impatience tends to contribute to the response we see in people who, in our loved ones, who are really trying, more often than not, navigating the world through their senses and through their intuition and through what they see and feel. And often that's mood, it's lighting, it's our anxiety and demeanor, it's an empty belly or a full belly, it's constipation, so it's all of those things that they feel versus what we tell them, much less important as the brain fails. So we need to kind of re-gauge how we're going to plan our interactions with a little more insight around what they have to work with in terms of their remaining capabilities. So certainly we need to adapt to change, and that's not always easy. But the onus is on us as care providers and caregivers and family members to change and to adjust and redefine how we're going to set the course for the day, because they are living in the only reality that they have access to. And so it's up to us to understand it and plan around it. And that's what we as consultants are here to help you with, is to try to kind of redefine the new course that you're going to take to make the best of your days. So in summary, all behavior has meaning. If I've said that at least 3 times, then please, if you take one thing away today, have that be it. It's not intentional. It's intentional in that they are responding in the only way that they can. And it's up to us to look at all the contributing factors around them and help make those the best stimulus and stimuli that they take in, so that we can bring the best out in them. So changes in the brain cause people to perceive the world much differently, and they're going to respond based on what they have, what the messages they're able to interpret. And helping identify those triggers and creating strategies is really is the only way we can truly navigate this in a way that ensures that we're doing all we can do to understand that person and what we need to do to support them every day. So
thank you so much, Leona, for all of that information. That was wonderful. We do have some questions coming in through the chat, so I want to make sure that we get to some of those.
Sure.
I'll just scroll up here. Okay, so my husband is having some issues with going to the bathroom. He's not sure what to do when we get to the bathroom, and when I try to help him with his pants, he says no. Do you have any suggestions?
Mhm. So what we often do with situations, or with this type of example, and unfortunately the example is common, but what isn't is what are this what is this individual's capabilities? What other are they able to perceive the toilet to be the toilet? Is the environment warm enough? Do they understand who you are and what your intentions are? So what we would do certainly in this example is work with you, the caregiver, to get a little more information, obviously, about your husband's capabilities. Is there times of the day where he's more approachable? So a lot to be done in terms of assessment. And then we would look at what you've used, what you've tried so far, and should we retry one of those strategies with a bit of a different add-on or change up, and what other strategies, certainly can we trial. So I would recommend, because there's a lot more information that we don't have, for understandably with time. So I would encourage you to connect with your care coordinator, and connect with a consultant to look at some strategies. And there are other resources too that we may have you consider just looking at in the interim. Teepa Snow has some great videos on personal care that I would recommend you look at. But certainly as a consultant, we would be more than willing to help you work through that, which would be looking at the uniqueness of your husband's personality and the rhythm of his day, and are there any other tasks or interactions that you're struggling with, and so forth. So great question, but certainly it would be an individualized approach to help you achieve better success, because it's an important one. Mm-hmm.
Absolutely. Thank you.
Yeah.
Another question here is, how do I know when an assessment for my parents is needed by a consultant to develop a care plan? This was also part of the question. Oh, at this point in time, she is living at home with her husband and is assessed at the moderate range of dementia.
Mm-hmm. Mm-hmm. So, I mean, when you're faced with responsive behaviors that are really impacting on your ability to care for your loved one, then you can certainly, whether you're involved with home support services, a care coordinator, it's always advisable to reach out when you're struggling with being able to provide the necessities of the day for your loved one. So again, encourage you to talk to your care coordinator, your home support agency, if they are having, I don't know your situation, but if they have any suggestions in terms of, or be a part of at least the discussion around what their observations are. What do they find if they're providing some of the same service? And really look to the team to figure out, how we can support you on a go forward basis.
Excellent.
Yeah.
No, the last question I have here is, when would you start to label items around the home?
Mm-hmm. And you may try one drawer and see, or a couple of things that this individual, for like if there's certain parts of getting ready in the morning, they are maintaining their independence, or if you see that there's something they're not gravitating towards or doing, whether it's maybe if you're going out for a drive and you tell mom to grab, it's cold out, mom, maybe you want to grab your coat, and she's not seeming to register what you're telling her. Anything that you see that would be something they wouldn't understand verbally, label it and see if it helps. Refer them to it and see if the label helps. Just start somewhere. I mean, really, it's a lot of this is trial and error, and words that would be familiar, would be where I would start. The more common, sock drawer, or cracker cup, the crackers. in the cupboard, like if they like to go and get crackers throughout the day, and you notice that they're not anymore, or they're going to the wrong cupboard, or the remote control. Well, remote controls are always tricky, but anything that they would normally, seek out in the course of the day that you may have noticed they're not seeking out, or they're puttering a little more, or they're pacing around a little more, not necessarily going for the crackers. Try it and see if it helps. And then again, we always try to support the loss of capabilities. So if you notice that progresses, then certainly give them the benefit of labeling as much as you feel comfortable labeling. That would help them maintain that independence. In long-term care, a name on a door was often what people used to find their room.
Okay.
Sock drawers are putter drawers are important. Always a good thing to provide for people who like to collect throughout the house, or collect throughout their environment. Create a drawer of interesting things in the top of the nightstand that they can spend some meaningful time rummaging through.
Excellent suggestions. And we just had one more question come through the chat. So what if the TV is a reality for the person with dementia? How do you solve that?
A reality? Yeah, it can be quite problematic. And often we see behaviors as a result of exactly that. So it may be a good idea to start thinking about other meaningful activities that don't promote a confusion around reality. And I mean, certainly, and I had a lady who, when the fires were in the West, very traumatic. She couldn't stop believing that. We've had many examples, but this was one that was just traumatic in that she believed that we needed to leave because the fires were coming, and it was watching the news every night. So I would encourage you to move away from television as entertainment if it's starting to cause anxiety, for sure.
Absolutely. So again, looking into that environment. What could
That's
be
right. Absolutely. Yeah.
Okay.
Yeah.
Thank you so much, Leona, for all of your time today.
Welcome. Thank you for having me.
Absolutely. And I want to thank everyone for their questions and for tuning in today. So if you'd like to send some comments about today's topic, or if you have suggestions for future topics, you can pop that into the chat or call our Infoline office. The 1-800 number is listed on your screen there, so you should see that. And if you'd like to have a confidential call with one of our Infoline staff regarding behaviors and discuss some strategies that might work for you, or if you have any questions at all about dementia, you can certainly call our Infoline, and that's our 1-800 number. And the Infoline staff are wonderful, and they're happy to help for that.
Can I leave them with one more tidbit?
Yeah, sure.
Quick tidbit. I just one little tidbit I want to leave you in your toolbox. If you have someone who is angry, if your loved one becomes angry, there's two magical words that I always encourage people to use. With a smile on your face, say, "I'm sorry." Two simple words go a long way. That's it.
Great advice, and something that we can all do on a daily basis too. So this session was recorded and will be hosted on our ASNS YouTube channel, so you can refer back to that, and feel free to send the link out to family and friends so they can also learn more about the topic. I'm going to use this last couple minutes to put in a plug for our virtual family caregiver series. We have a couple of those programs starting up in March. So this is a 6-week series that's held 1 hour a week, and it's held on Zoom for Healthcare online. It's open to friends and family members who are providing care for someone living with dementia. So it really helps to give a great overview of dementia. We talk about planning for the future, communication, behaviors. So if that seems like a program that you're interested in, please give our Infoline a call and they can provide some more details and register if you wish, register you. So I think that's it. We will thank everyone, and I hope that you have a wonderful afternoon and enjoy the rest of your day.